What I'm going to do is just take you through what I think are some new frontiers in health security that cover a range of different areas, one of them being bioterrorism, but some other areas as well. The thing about infectious diseases, which are the agents used in bioterrorism, is that they're different from other types of diseases such as diabetes or asthma, because if one person's infected, it can be transmitted to the next person. And so it's got this capability of causing epidemics. A pandemic is simply an epidemic that becomes global, okay? And they're characterised by a very rapid rise in cases. So it's not like diabetes, which might rise over decades. They rise with the number of cases rises within days to weeks. So you get immediate impact on systems and an immediate need for surge capacity. And the cause of an epidemic may be natural or unnatural, but the impact is the same. Travel and globalisation means that an infection anywhere in the world can spread really rapidly to another country in a matter of days or weeks. That just shows you how SARS back in 2003 spread around the world so easily from Hong Kong, set off very serious epidemics in Canada, Vietnam, Singapore and a range of other countries. So infectious epidemics then have this capacity for major, almost instant economic disruption. You have disruption of critical infrastructure, and they can sometimes follow natural disasters because of breakdown in systems. So during SARS, for example, we saw a near bankruptcy of travel-related industries, especially small and medium businesses. The US anthrax letter bombs in 2001 resulted in the shutdown of the US Postal Service, which then had massive flow-on domino effects to a range of other systems. And this is why governments all over the world invest in planning for the health, economic and social impacts of pandemics. Now, when we look at investment in biosecurity research, the vast majority is on drugs and vaccines. Whenever there's a new epidemic or something going on, Ebola, MERS, all you hear about is development of drugs and vaccines. The investment in developing other types of research, whether it's on systems, behaviours, non-pharmaceutical countermeasures, etc., is minimal. Yet on the other hand, when you look at what's been used to control these serious epidemics, look at Ebola, MERS, SARS, drugs and vaccines played zero role, zero. Okay, you've got to rely on your non-pharmaceutical countermeasures, whether it's personal protective equipment, infection control, etc., and other systems type interventions to control these epidemics. And even look at the pandemic of 2009. These are data from Australia. The solid red line is the 2009 data and the others are previous years. The yellow arrow shows you when the vaccine became available. So the vaccine came in too late for the party, right? The epidemic had already peaked and declined. The vaccine had no impact on that peak. So I'm making the point that you need other interventions as well. Yes, drugs and vaccines are important, but there's many other things that come into play to control an epidemic. This is from the Ebola epidemic, and you can see that in that instance, the military was required, not just in the local countries, but we saw militaries responding from around the world, from the US, from China, from the UK, in some instances, just to build capacity and build field hospitals. This is the one case of Ebola in Dallas. Well, there were 2 nurses that got infected as well. That's another story. But the point here is about personal protective equipment, and there's the guy removing the hazardous waste in his full gear and the police standing around in just their uniforms. So it raises the question, who looks after their needs? Who's thinking about their exposure to infections? We have seen this escalation in the number of serious epidemics hitting the world in the last decade particularly, as seen in this graph. And if you look at influenza, we've seen a real clustering of novel avian flu viruses in the last 10 years. And these can't be explained by any other reason. The rate of rise in these viruses is not explained by any other factor. Now this news story is just to highlight that biological warfare is a real threat. It's a real threat, but it's not as visible as other kinds of threats. So we've heard a bit this morning about terrorism. What is it? there's actually no universally agreed definition, but the term was first used in France to describe the systematic use of terror by the French government against its people in 1793. And the term has changed meaning throughout history and is now often used to describe the actions of non-state actors against states. And Anthony went into some detail about some of those distinctions. But most definitions include the use or threat of serious violence to elicit terror. Bioterrorism, on the other hand, this is one definition, and again there's many different definitions, is an attack using deliberate release of viruses, bacteria or other germs to cause illness or death in people, animals or plants. But in terms of creation of terror, it really depends on whether the attack is recognised as unnatural. If it's not recognised, there's no terror. So a biological agent as a weapon can be used against an individual just like a gun can be used against an individual, or against populations as a bomb can be used against populations. But the difference is a biological weapon used against one individual, if it's infectious enough, can go on to infect numerous other individuals. So it can spark an epidemic. So it's a different kind of weapon. When we see a building collapse, even a child can tell you if it's natural or unnatural. They can tell you it's a bomb or it's an earthquake, right? It's not that hard to tell if it's natural or unnatural. And that's our thinking in terms of terrorism is very much around that, being able to pick when a terrorist attack has occurred. The key difference for bioterrorism is it's very difficult to recognise. Most Category A bioterrorism agents occur in nature. Ebola, plague, anthrax, you get natural outbreaks commonly. The only one that can be recognised straight away as unnatural is smallpox because it's eradicated. But there is a default assumption by public health officials that all epidemics are natural. And I come from a public health background, I've worked in the sector, and I know that this is true, that every epidemic is investigated with the default assumption it's natural. So then to summarise those key differences between terrorism and bioterrorism, in the case of traditional terrorism, the weapon is visible, it's macroscopic. In bioterrorism, the weapon is invisible, it's microscopic. In terrorism, the attack is recognisable as unnatural. In bioterrorism, it may appear to be natural. So the modus operandus may be stealth. Terror is present in traditional terrorism, but may be absent in bioterrorism if it's not recognised as terrorism. The target is usually many people in the case of terrorism. In bioterrorism, it can be one person or many people, but the end result can be an epidemic either way. And also you've got this concept of a one-hit attack, which is the case when an agent that's not infectious is used, such as anthrax. It's the spores that are used, and that's just a one-hit attack, or contamination of food, for example. On the other hand, if it's something like Ebola or smallpox that's infectious, a few releases will result in an epidemic or a pandemic. So distinguishing a natural from an unnatural epidemic is actually very difficult if the agent is highly infectious, because once the epidemic is seeded and started, regardless of whether it was natural or unnatural, it's going to look the same. So you actually need forensics, law enforcement, those kind of investigations to determine if the origin was unnatural. There's a really well-known case of the Rajneesh cult, a salmonella attack in Oregon in the 80s, which was the largest outbreak of salmonella ever in the United States at that time. And the public health authorities, including the US CDC, did not pick it as unnatural. There was a politician who thought that this was unnatural and actually blamed this cult, the Rajneesh cult. And the public health authorities shouted him down and refused to believe him. He was kind of made to look a bit crazy, and the only reason it was found out as unnatural was that 6 months later Rajneesh himself confessed to the attack, and when he confessed it wasn't believed. But a year later the FBI actually raided the ranch and found the exact match of the outbreak strain. And if you look at the actual outbreak, it's clear as day that it's not natural, but nobody picked it. Why was that? So the lesson there is not about the terrorist potential of cults, it's about the inability of experts to interpret data correctly. It's a matter of, is the glass half full or half empty? It's about the normal human tendency we have to override facts with beliefs. And in this case, the public health authorities had lots of experience with foodborne outbreaks. And they're generally because of unsafe food handling. So that's the dominant paradigm of thinking, and that's what they just defaulted to, even though it didn't fit the facts. Now, the real game changer in bioterrorism is genetic engineering. We do have methods that are publicly available to engineer deadly pathogens. And the question is, if methods to harm people are available on the internet, will terrorists use them? If an engineered outbreak occurs, how do we know it's unnatural? You might remember this movie, Gattaca. I think it's about 20 years old now. At the time, it was very much science fiction, but everything in that movie is now possible. It's about super engineered human beings that live in an elitist society, and naturally born humans are an underclass. One of the most revolutionary advances is CRISPR-Cas9, which is a precision gene editing tool that's been available only in the last 3 years, that's really changed capability in this area. Already in Sweden, they are editing healthy human embryos. It's actually now possible to edit anything at all that's living, that's got DNA, whether it's a plant, a virus, a bacteria, a human being, an animal. You can bypass Mendelian inheritance so that everything we learnt in high school about the mathematical probability of inheriting your mother's eye colour or your father's hair colour, it can all be bypassed, and you can introduce hereditary characteristics. You can even eradicate species with this technology. In 2016, the former Director of National Intelligence in the US, James Clapper, called CRISPR-Cas9 a weapon of mass destruction. He listed it among the top 10 existential threats to humanity. So dual-use research of concern, what is it? It's research that's intended to benefit humankind, but which can also result in harm, and we've heard a bit about it today. It can be in science and technology, in biology, in artificial intelligence, in computing, robotics, drones. In terms of infectious diseases, the harm can occur either by a laboratory accident, where something that's created in a lab is accidentally released, or by deliberate release. And it's been controversial since 2011, when scientists sought to publish methods for engineering avian influenza viruses. So the two types of DIRC in infectious diseases are synthetic genomics, which is creating a virus entirely artificially in a lab, which has been going on since 2002. There's over 50 unregulated companies in the world doing this. And they have voluntary code of conduct. And then there's genetic modification of pathogens using tools like CRISPR-Cas9, which has been documented since the Soviet bioweapons program. And the H5N1 avian flu controversy really brought it to a fore. So H5N1 is bird flu. It's flu that affects birds. It doesn't affect humans unless you've got really close contact with sick or dead birds. So there have been hundreds of cases in the world for the last 20 years or so, but it doesn't spread from human to human. So what these scientists did was create an H5N1 virus that was transmissible between humans or between mammals. It caused quite a furor in 2011. Initially, the United States at least put a moratorium on funding of this kind of research and publication. They stopped the publication of these two papers. The scientific community was really polarised. There was one side arguing that scientists should have the freedom to publish whatever they wanted, and the other side arguing that this was actually really dangerous. In 2012, the publication was allowed, and pretty much the gates have opened, the horses have bolted. It's all out there. There was a renewed moratorium on funding in 2014. The US government did a report, sort of a risk-benefit report, which is very non-committal, and the European Union did a similar report. So the argument for doing this kind of research is, in the case of flu, there is a threat of a pandemic occurring due to random genetic mixing in nature. This can arise from bird flu that mixes with human flu. And we need to develop drugs and vaccines, so let's create a virus that could cause a pandemic and then create a vaccine against that, which is kind of a fallacious argument because with the current technology for flu vaccines, you need an exactly matched virus, yes, a strain for the vaccine. You can't just guess. And 2009 is a good example. The kind of vaccines they developed were the wrong vaccine for the virus that actually emerged. So it's a question of probabilities. What's the probability of a natural pandemic arising, P1 in this diagram, versus an unnatural pandemic, through a lab accident or terrorism. We can just work it out on the back of an envelope. We know that natural pandemics occur every 40 years or so. So we can just say the probability of a natural pandemic is 1 on 40 or 0.025. P2, the probability of an engineered pandemic strain already existing, it already exists, so that's 1. So there's some factor K, 1 times K. K is the probability of nefarious use of published methods for engineering these viruses. Does K equal 1? So if you had a reproducible method of making a 3D printer gun on the internet, what's the probability that somebody will use it? I think we all agree it's 1, right? So why would P be anything other than 1 for terrorists undertaking genetic engineering of pathogenic viruses once the methods are published? So just on my back of the envelope calculation, it's a no-brainer. The risk is far greater than of an unnatural pandemic is far greater than of a natural. So who's looking at this? Who's doing risk assessment? Who's measuring these probabilities, ethics, oversight, decision-making, accountability? What about the community? You know, if a pandemic arises, who's the biggest stakeholder? It's the people, the community. They're the ones who are going to be infected. Who's asked them? There's already, you know, this is just another story about a SARS-2 virus. Resurrecting smallpox, it's technically possible. In fact, just last week, this news story hit. A group in Canada synthesised from scratch in a lab an extinct pox virus for $100,000 using mail-order DNA. So we know now, it's very similar, it's genetically very closely related to smallpox, this virus. We did a survey of American and Australian people in just general community, 600 people, to find out what they knew about this kind of research and what they thought about it. We asked, have you previously heard, we gave them a bit of information, have you previously heard of this kind of research? 61% had never heard of it. Then we gave them a series of bits of information, took them through some scenarios and asked them the same questions at the beginning and the end. After getting all the information, at the beginning about 30% said it was unacceptable to engineer viruses, but at the end of it 44% thought it was unacceptable. And then there's the insider threat. Numerous cases of misconduct in science, some involving infectious diseases. It's a real issue. The US Commission on the Prevention of Weapons of Mass Destruction says, given the high level of know-how needed, we should be less concerned that terrorists will become biologists and far more concerned that biologists will become terrorists. In fact, the key suspect in the anthrax letter bombs was a US Army scientist who committed suicide when he was about to be charged. So there are numerous examples. It's quite real, this insider threat. So where does this kind of DIRC research happen? Well, it happens in universities, in scientific institutions, do-it-yourself labs, homes, anywhere. You can buy a lab in a box on the internet today. You can set up experiments very easily anywhere. We have BioFoundry here in Sydney. The philosophy of this do-it-yourself lab is that anyone should be able to do science. It should not be the domain of scientists. You don't need training, you don't need qualifications. You can just walk in off the street and experiment, and that's a great thing. So regulation, universities are strictly regulated on research that we do. But in these do-it-yourself labs, there's no regulation. You may not even know the lab exists. And research that would not be approved in a university can be done in a do-it-yourself lab. Who's monitoring these labs? Who even has a system to identify these labs? What about vectors for bioweapons? There are now artificial insect drones that can be precision targeted attacks, and there are actual insects with radio transmitter backpacks that can also perpetrate precision attacks. And then there's the dark web. So we know that biological agents could be traded, are being traded on the dark web. Do the people who look for this kind of stuff actually know what to look for? You know, do you just look for the word smallpox? Or are there other more nuanced ways for looking to what's actually being traded on the dark web? This particular student got arrested for trying to buy ricin on the dark web. So basically what we've seen is this acceleration of threats and infections, you know, they're global. You can't contain them within geographic borders. You can't have just a localised strategy. Any kind of epidemic, whether it's natural or unnatural, can affect the whole world very rapidly. There really are no systems of global governance, legal, ethical, for research conduct. What we have is vertical systems of critical stakeholders: health, law enforcement, military, emergency management, etc. All essential responders, but working vertically. There may be, top-level communications, but on the ground, there's usually problems. You see conflict between agencies. So we're doing some research around this area in an NHMRC research centre on epidemic response, a whole lot of stuff. I'm not going to go into the details. One of the things we're looking at is what if there's a smallpox epidemic. Smallpox was eradicated more than 40 years ago. In that time, there's been such amazing advances in medicine and science that people can live with conditions they couldn't live with back then, with immunosuppressive therapy for cancer, for autoimmune diseases and so on. We estimated that almost 20% of the Australian population is immunosuppressed, okay, which means the vaccine's contraindicated in those people, technically, and they will get much more severe disease. And what we did was we looked at the estimation of, and Valentina, who did this model, is sitting up there. Put up your hand, Valentina. What we saw was that if you don't account for this immunosuppression, you think the impact of the epidemic is going to be less than it's actually going to be. And then I'll just finish up by talking about other aspects of health security to do with data and technology, which is essential in medicine and healthcare these days. But again, it's dual-use technology. There are risks and benefits. We know about the Human Genome Project. It's really amazing, the kind of data that's at our fingertips now, publicly available, genetic data on anything at all, really. There's a lot of research that's done using data linkage. So, for example, an Australian study found that if you have a lot of CT scans, your risk of cancer goes up. And that was done by data linkage, by taking patient records, linking them to cancer data sets and other data sets. So it's really useful to do this kind of research. We've got a big push for electronic health medical records in Australia. We've just heard that in the budget this year in Australia, that we'll be having the My Health record as an opt-out system. So if you don't opt out, your record's going to be up there. And yet on the other hand, simultaneously, we've had these unprecedented hacks on hospitals happening in the last 3 years particularly. So in the US, in the UK, Luca talked about the WannaCry attack. It really crippled the NHS in May this year. And you saw surgery having to be cancelled, patients having to be turned away, ambulances diverted. It caused absolute chaos in the health system. So on the one hand, you've got this aspiration to be paperless. On the other hand, you've generally got very poor cybersecurity practices in the healthcare system that leaves it vulnerable. And of course, as Luca also mentioned, we've realised a journalist from The Guardian uncovered that all Australians' Medicare details are being sold on the dark web. The government didn't know about it, the law enforcement agencies didn't know about it, a journalist uncovered it, and it's sparked now a series of, this was also just a few weeks ago, so it sparked a series of reviews, and we'll have to see where that leads. Precision medicine is another buzzword you hear about. Precision medicine means we can take all this data, this knowledge, your genetic makeup, your specific information about you personally, and we can tailor your treatments for your particular genetic and biological makeup, which is great. But on the other hand, it also enables precision harm, right? We can create harm specifically for you, to target you. And I haven't even seen anyone talk about precision harm. We do know, though, that devices can be hacked. So pacemakers, insulin pumps, it's already well recognised that these devices can be hacked. Dick Cheney had his pacemaker disconnected from the internet, from the Wi-Fi, because that risk was recognised for him. And in terms of medications and what you consume, I'm sure many of you have heard the case of Alexander Litvinenko, who was killed with polonium in his tea. Those are really obvious ways of assassinating people, right? There were these Tylenol murders back in the 1980s in the US, where someone basically laced all the Tylenol, which is what we know as paracetamol, with cyanide. 7 people died in the first attack, and then there were a whole bunch of copycat attacks. And that changed, to some degree, medication security and brought in use of blister packs, etc. But this is the kind of capability that exists right now in the world. So we know that the Office of Personnel Management was hacked a couple of years ago. It was probably the most catastrophic hack in the US. So every federal employee, more than 20 million people, I think. And at the same time, or very close by, the Anthem Health, which provides healthcare to most federal government employees, was also hacked. So if those two databases are linked, then you can target an individual in this way. Here's Judge Joe. He works on the Supreme Court. What case is he hearing tomorrow? He's 69 years old. He's got ischemic heart disease. He's got a pacemaker. These are his drugs. He's on insulin. That's interesting. Does he use a pump? He gets his medication from the downtown pharmacy. This is his genetic profile. What's he susceptible to? Right? This is the kind of precision harm that can be done today. And I can tell you nobody is looking at this in a systematic way. Nobody is developing capability, but we need to develop this capability. We've heard recently in Australia about Valium being tampered with. This was about a month ago. So there's lots of cases historically of this kind of medication tampering that's been documented. In Syria, 34 children died from measles vaccine. And what was in the measles vaccine? An anaesthetic agent. Related to pancuronium, so it paralyses your breathing. Why would an anaesthetic agent be in a measles vaccine? It's just telling you any of these things, drugs, vaccines, can be used as weapons to target people. So we're really looking at new frontiers in health security. All these factors kind of coalesce together. There's increased risk of pandemics, whether natural or unnatural, cybercrime, data breaches, medication security, precision harm, things that we haven't even thought about, and very poor mechanisms for regulating, responding and mitigating these things. So I think, we have got very new frontiers, new developments in science, in information technology, new tools, new approaches, new systems. We need new ways of thinking about health security. We can't live in the last century because everything's moved on and our systems are still stuck in the last century. The way we think is still stuck in the last century. And health-centric solutions are no longer fit for purpose. I noted that the government review on the Medicare data being sold on the dark web was being led by medical bodies, Australian College of GPs, and that's great. We need medical experts to look at this, but the problem isn't medical. It's a cyber security issue. Where are those experts leading this review? I mean, I'm sure they are those experts, but all I read about in the newspapers was, peak medical bodies leading this review. So really, we need more than just health-centric solutions. We need multidisciplinary capability and different types of risk analysis, modelling, forecasting, countermeasures for things we can't even imagine right now. And we need substantial cross-sectoral capability in health security that brings in all the different sectors. And I think we need someone to take responsibility, because at the moment, nobody is responsible for any of this. And that's it. Thank you.